Yes, so good morning, and I wanted to extend, or let you know that it's a privilege to be here to speak to you about collaboration. I wanted to thank Ali, a longtime friend, for inviting me here and recognize and honor the other faculty who have tremendous expertise. It's an honor to be on stage with all of you. So my disclosure is that for the past really 32 years, but specifically in the past 15 years, I've been a partner in a multi-specialty group that consisted of 8 IRs, 6 vascular surgeons, a cardiologist, a vascular medicine specialist, a neurologist, and interventional neuroradiologist, all as part of a large diagnostic radiology group. Just recently, I become the chief medical officer for Penumbra, but for the past 32 years, I've been in this practice. So why are we even discussing this? And let's start with this. Is collaboration absolutely necessary? Well, we're going to argue later, yes, but to start with, many of you are in your own practices. So we could say if you want to stay like that, you can, but you heard Ali speak about the future. So for today, you know, if we're in August 2021, you're fine. I have a feeling in the next few years, though, that's going to change a lot. Physicians, in many instances, as you know, are being commoditized. And the more we're together, the more power we have. We can eliminate the turf issues. Mark talked about changing from fee-for-service to quality outcomes. When we eliminate turf and billing and what we make, and if we can share in that, I think quality becomes a much bigger, important point for us, and patients do better. I think as a group, we've learned in our own situation, we can actually be more profitable working together. We can provide comprehensive vascular care. We can standardize quality. So if you walk into a hospital and you have a carotid duplex in one lab and it shows a 60% stenosis, and then someone else does it in the same hospital, read by another specialty, that shows a 90% stenosis, one person's on Plavix and the other person's under a knife. That doesn't seem right. So we want to standardize our quality. Something we'll get into a little bit later is improving our own quality of life when we look at workflow and shortages. And then I think very importantly to our administrators, to our providers, and to our patients, we can provide a comprehensive practice of vascular care. We all remember these days when, or many of us older people remember the days when multiple specialties would get together, would talk over cases, would come up with a plan. But nowadays, I think, you know, it's one doctor kind of running the show alone. We propagate notes and electronic medical records that are essentially meaningless, pages of meaningless information with a one-line summary. There's very little communication. There's a lot lost in the science and art of medicine when we practice like that. So who are the players? Well, we've alluded to that. It's really everyone in the endovascular world. I'm going to give you the interventional radiology perspective as we move forward. And we have these cliches. We talk about bridging people together, and there's a lot of ways we can do that. We can, you know, look at practice growth and RVU improvement, quality of life. Mark mentioned earlier this cross-pollination, intellectual cross-pollination, which I think has been the single most enjoyable, most satisfactory part of this whole process for me, learning different methods, different techniques from people who train differently. But we do have to admit that not all hybrid model works, and many of them are ugly. And they get ugly because of cultural differences, the way we've trained. There's training differences, finances often get in the way, and then egos get in the way. So we have to overcome all that. What specifically can an IR bring to the table? Well, we have expertise in multiple imaging modalities. Our training, unlike a surgeon, to a detriment, we don't operate, but all of our training is focused only on percutaneous skills. We do train in territories outside of the major veins, legs, and aorta, so we look at mesentery, all the oncologic areas, and many other areas that are really rapidly growing now, and we'll get into that. As with cardiology, surgery, vascular medicine, and other specialties, it's an extremely innovative specialty. Over the years, going back to Julio Palmez and on, there are hundreds and hundreds and hundreds of patents and ideas that interventional radiologists have helped develop. And then the idea of integrating technology, fusing ultrasound, CT, MR, fluoro, and nuclear modalities to provide image guidance is really what's in our wheelhouse. Now, what are some of the problems with IR? Why hasn't this always been, if this is also true, what has been IR's problem? Well, Ali showed you some slides that showed you 30 years ago, IR was doing almost all the endovascular, well, even before that, maybe back in the 80s, was probably doing 80% of this work. But IR grew out of DR, diagnostic radiology, a non-clinical specialty. And that has been a huge chain around IR's leg. That's been a huge hampering for us. The solution for that is IR is now broken off from DR, diagnostic radiology, become its own specialty, has its own training, and has recognized that they can't play in any sandbox with any of the people on the stage until they force themselves to become a clinical specialty. What about entitlement in the past? Ali put up a slide earlier. In West Virginia, the IRs felt that they deserved this. They came from a home of diagnostic radiologists where all the imaging came in. You sat back and you waited for the work to come in. You didn't have to build anything. Well, we all know that that's fairy tale. That doesn't work. But lately, I think you see in the past 10 years in outpatient centers and building practices, IRs have been really leading the way. If you look at billing and coding expertise, the SVS, SCAI, SIR are all working together. But I would tell you, if you look really deeply into it, it's the SIR expertise that's really been fighting extremely hard in the billing and coding. So I think that entitlement is has gone away for the most part. One of our big problems is our ties to radiology groups, which we already mentioned. And then these previous history of turf wars. But I would say right now, the arch enemy for an interventional radiologist today is a diagnostic radiologist, not a vascular surgeon or a cardiologist. I think those are our allies. But there are challenges for all the specialties. What are they? We lose independence. There's an uncomfortable feeling when you get away from your own genetic species. We all trained with people we know, we think alike. So it takes a little work to work with people in other specialties. We have to value the work performed. There are call responsibilities and compensation issues that we have to deal with. And this has all been looked at in the literature. In fact, this is an article that was published in a journal called CIRSE, it's a European journal, looking at why vascular surgeons and interventional radiologists collaborate or compete. And basically, what they acknowledge is that a lot of the problems really were self-serving, and that when the two groups recognized that there isn't a single monoculture, and we recognized and celebrated differences among each other, that we could all get along and work well together. Also, in an AMA article, Ali alluded to some of the publications before. This is from an ethics article in the AMA, where they talk about outcomes in terms of complications, patient outcomes, avoiding medical errors, and providing effective patient care is much better when the groups collaborate. Now, if that's not enough, let's look a little bit at innovation over the past, this is since my career, starting with the first Palmes stents, going out to now. Look at all these new things that come along. We all have to learn these after we're done training. It's limitless. And as vascular surgeons, you may say, well, I'm good at all this, or I can handle all this. But where are we going tomorrow? This is where we are now. And this is a lot. It's a lot for any one specialty to manage. So the idea of collaborating with people who have other expertise may help. But some of the areas in terms of endovascular, if we get out of atherosclerosis, we're doing tons of work now with benign prostatic hypertrophy. There's great randomized trials showing excellent outcomes, management of hemorrhoids, obesity management, which we're doing with embolization, arthritis, geniculate artery embolization. These are all areas that are untapped. If you think that PAD is common, if you put all this together, PAD is a speck on this map, okay? So where we're heading and what's available is enormous, and it's a matter of getting, but not one person, not one specialty can manage all this. Then we get into the venous work and pulmonary embolism, where we don't think we've tapped more than 5 to 6% of this market, and many other areas that we're getting into. If we break it down by vessel kind of regions, there's a lot in the arterial world that's flat. AAA, cerebrovascular work. CLI is epidemic, but Short of that, there's not a lot of growth in many of the arterial areas. On the venous side, however, DVT, we're less than 10% penetrated in the iliofemoral market. Pulmonary embolism in its infancy, embryonic stages of what we can do. Mesenteric and portal interventions, recanalization of chronic occluded mesenteric veins, tips, this type of thing. But the huge growth area that's going to dwarf everything really is in embolization. And that's another entire skill set that is almost its own subspecialty. In fact, I would tell you right now, interventional oncology will dwarf all of endovascular medicine by a factor of 10 in 10 years. It's enormous what's going on there for hepatocellular carcinoma, renal cell carcinoma, lung cancer, lymphoma, virtually every type of tumor you can imagine. Women's health and reproductive embolization, obesity, as I mentioned, arthritis, prostate embolization, all of this still in our wheelhouse, still something that we can collaborate and grow together with. If none of that excites you, let's look at this from the Annals of Vascular Surgery, an updated physician's workflow model, which predicts a shortage of vascular surgeons and in fact concludes that before 2015, burnout, changing practice patterns, geographic maldistribution, and expansion of healthcare coverage utilization may adversely affect the ability of vascular surgeons to accommodate the needs of their patients. So we're in a situation now, like Ali says, we need offense and defense. Collaboration is one way with multiple specialties, in particular IR, since that's what I'm talking about, to accommodate that shortened workforce, prevent burnout, and provide a better lifestyle for all of us. So we can talk about the advantages, improving outcomes, doing more complex cases because of this cross-pollination of training, the ability to be more efficient with procedures, scheduling, cost sharing, effective use of supportive services, taking money out of the conversation removes turf, and as I mentioned earlier, providing our administrators, regulators, and patients with a comprehensive service line with expertise in all areas. IR, I should mention to you now, is an independent specialty. It's the first new specialty added by the American Board of Medical Specialties since 1977. It requires surgical or medical internship. It requires ICU rotations. Clinical time must be documented, both inpatient and outpatient consultative work. Rotations in other specialties are required. It mandates PAD and vascular lab training, and it's a 5 or 6 year program. In our practice, to give you an example, we perform slightly more than the fellows come out with about 500 lower extremity patient interventions annually. Our vascular lab does about 23,000 non-invasive tests a year. We provide full office and consultative services as IRs. Our training includes everything in what we would call conventional endovascular, plus all the oncology and embolization areas. And we participate in multidisciplinary conferences and have multidisciplinary scholarly activity requirements. As I mentioned, the big drawback on IR's part, or some of these complicating issues, really has to do with the tie to the diagnostic radiology groups. Their focus, their quality, their outcomes are driven by RVU production. Our focus, our outcomes, our satisfaction is driven by patient care and good outcomes, and there's a little bit of a problem there. But I think as we collaborate with other specialties, that's where the IRs, I think, find more satisfaction. So in our group, we did it many years ago. We wanted to solidify vascular interventional care in a competitive environment. We wanted to take turf out of the issue. It was a big challenge. It still is a challenge. There's a tremendous amount of attention to detail, financial compensation, the value of call, the ability to provide services, all have to be weighed in and factored in. It's not a static document. The way we look at things, we're constantly updating, reevaluating. But I could tell you that over 32 years in my practice, my closest colleagues, my associates, are our cardiologists and vascular surgeons and not the radiologists that initially hired me. I feel very foreign from them, in fact. So in summary, no. Today, right now, you don't have to collaborate if you don't want, but I don't think you're going to be able to get very far in the future. I think it's an option to enhance and diversify a vascular practice. It can improve quality. It can improve quality of life. There are some challenges. There are cultural differences. I think they can be overcome by paying close attention to detail and by recognizing that we are different. We should celebrate our differences, not fight our differences. If we celebrate our differences, we can be a more efficient engine and we can provide comprehensive vascular care. Thank you very much.